Hi, well, I'm Dr. Baldessano. So Athos is the one who gave me this title. Now, okay, there it goes. Actually, I want to go back. Thiopurines have no role in the management of pediatric IBD. You know, one thing about with these debates, I think sometimes we have to be careful that we don't try to win the debate and mislead the information. And I don't think Athos did that. I think he did a great job here. But I'm also going to try not to do that either. So really, when I look at the data, I think what you're going to see at the end of my talk, I'm going to say thiopurines have a limited role in the management of pediatric inflammatory bowel disease. The one thing I want to stress is pediatrics. You know, if you went to the sessions earlier today, Steve Hanau, I think, gave a great talk, very well-balanced talk about adult inflammatory bowel disease. He did make a quick reference that, oh, this doesn't apply to the older patient, and I'm not sure his definition of older now, but I think it's like somewhere in the 60s, that he probably wouldn't use combination therapy. And then when he talked about younger patients, his younger patients were under 30, and he thinks these are a special group. So again, as I talk about this, this is going to apply to pediatric IBD. These are my disclosures. And everything is risk versus benefits. So I think the questions we all need to ask ourselves before treating a patient is, what are the risks of serious infections with immunomodulators and anti-TNF therapies? What is the risk of malignancies with immunomodulators alone? What is the risk of malignancies with anti-TNF alone? What is the risk of combination therapy with immunomodulators and anti-TNF? And can we mitigate these risks? Risks are important to patients, even small risk. And the risk that all our families worry about is cancer. Is there a risk of malignancy with thiopurines? Azathioprine is known to be a human carcinogen based on sufficient evidence of carcinogenesis from studies in humans. It was first listed in the 4th Annual Report of Carcinogens in 1985. Initial evidence was with transplantation, but now it's true with chronic inflammatory disorders. Multiple mechanisms of carcinogenicity with thiopurines. It damages DNA. It decreases immunosurveillance. Taking 6-MP azathioprine results in 6-thioguanine incorporating into cellular DNA. This results in a significant absorption of ultraviolet radiation, leading to DNA damage. This was a study that was done a few years ago looking at the mutagenicity assay. If you look at the slides to your left, the top slide are IBD patients, both adults and pediatrics, that have not been exposed to a thiopurine. If you compare that to the slide below of patients who have been exposed to a thiopurine, and look at the y-axis, it's an exponential increase in the mutagenicity of these patients. Looking at mutant cell expansion, which is the slide to your right, the top slide shows that patients who haven't been exposed to thiopurines, actually with kids it's 0 and not measurable, adults it was a little increase, but if you look at the thiopurines, clearly increase in this mutant clonal expansion. And this bottom slide shows that this is dependent on the dose of the thiopurine. And this is a slide that, again, it's maybe not that appropriate for pediatrics, but it shows that there was an increased risk in lymphoma rates in these different age groups. The nice thing about it, though, is when you stop the thiopurine, you seem to go back to the unexposed rate. This is a slide that I think is more important in pediatrics, is the hazard ratio for years of exposures, that after you've been on this product for 3 years, there's a significant increase in the risk of developing cancer. So with our patients, after they've been on for 3 years, you need to think to yourself, do we need to continue this agent? Because now the price I'm going to pay for 4, 5, 6 years later is going to be much greater than the price I paid for the first 3 years. And non-melanotic skin cancers. What this is showing is that patients who have been exposed have an increased rate, and this is a lifelong rate. It does not go down once you stop the thiopurine. And as I mentioned before, this is because you have an increase in ultraviolet radiation absorption. If we did this study in pediatrics, which we really need to do, 80% of our ultraviolet radiation exposure happens before the age of 18. It's our pediatric patients who are at greatest risk for these skin cancers. Now, you might say non-melanotic skin cancer, so you just cut it out. The one I have from my 6MP exposure, it was an 8-inch incision to remove my squamous cell. One of my patients, a young woman that I don't follow her anymore, but I know her as a friend, she's in her late 20s now. She's had 12 skin cancers, and some of them have been on her face. I think if you talk to her, she won't say that this is a trivial problem. Now, this is a paper which was done at Penn where they looked at increased malignancy risk with adalimumab combination therapy compared to monotherapy. They looked at randomized clinical trials, about 3,000 patient years. Follow-up was 1.5 years. What they showed that there was no increased risk of adalimumab monotherapy for the cancers. If you had adalimumab and an immunomodulator, it was a 3-time increased risk for malignancy other than non-melanotic skin cancer. Adalimumab plus immunomodulator, 5 times increased risk of skin cancer. Adalimumab plus immunomodulator, 8-time increased risk of lymphoma. Okay, but clearly one of the big things that we worry about is hepatosplenic T-cell lymphomas. Now, this is a picture that Jeff Hyams gave me. I am not implying that this is what Jeff looks like when he takes his T-shirt off. Some people think it is. So hepatosplenic T-cell lymphomas, we all know about this. Again, it occurs between adolescents and young adults. It occurs, actually, if you look at the most recent data, it's 69.5% male. So it's actually 30.5% female. It's not only a male disease. And unfortunately, it's a very aggressive disease. Median survival is 16 months. It's almost universally fatal. So let's see, how often should we be seeing hepatosplenic T-cell lymphomas? Well, if you look at the databases for non-Hodgkin's lymphomas between 10 and 19, the chances is 1 in 50,000. 20 to 29, it's 1 in 33,000. So of these, ones that are peripheral cell lymphomas, that's about 10 to 15% of the non-Hodgkin's lymphomas. Of these, 5% of these peripheral cell are hepatosplenic T-cell lymphomas. So when you do all the math, it works out that the likelihood of developing a hepatosplenic T-cell lymphoma, so the background rate would be 1 in 5 million for this age group between 10 and 29. In the United States, we would estimate there's about 50,000 to 100,000 children with inflammatory bowel disease. Therefore, one would expect with that number of patients, we should see 1 case every 50 to 100 years as background incidence. At CHOP, we've already seen 2. Most big centers have seen a hepatosplenic T-cell lymphoma. Here, if you look at the columns, the third and fourth column just shows the incidence. Again, it's a low incidence of this fatal disease. 1 in 7,000 if you're on a thiopurine alone, and if you're on combination therapy, it's 1 in 3,000. The author, though, concluded that the risk appears to be particularly increased in patients receiving thiopurines, either as monotherapy or in combination with an anti-TNF agent. IBD patients receiving long-term thiopurine therapy are possibly at even greater risk. So conclusions, thiopurine use is associated with increased cancer risk. Risk of cancer with methotrexate appears to be small to negligible, but we really need more data. Anti-TNF therapy alone, and unfortunately I don't have time to present this data, does not appear to increase cancer risk. Anti-TNF plus thiopurines is associated with increased cancer risk, though not clear what amount is from thiopurines alone, particularly problematic in young males. So this is a study we all have seen hundreds of times. It's Jim's study where he started the study about 20 to 25 years ago. It took a long time to recruit. And it was a great study for the time. We've learned a lot about clinical trials over the next 20 years. One thing we know, endpoints matter. He used a modified Harvey-Bradshaw. And in the study by Best, they looked at different disease activity scores, and one of the conclusions is Harvey-Bradshaw, not even a modified one, a Harvey-Bradshaw is not recommended for prospective trials in Crohn's patients or Crohn's disease. Also, the remission rate. We hear all about this great remission rate, and this slide looks great since they don't have confidence intervals there. But it's interesting, at the end of 1 year, neither group had any linear growth. There has not been any studies of 6MP in pediatrics that has resulted in improvement in growth. Pediatric problem, the adults don't have to worry about getting their people taller. We do. From a sample size, it was only 55 patients. This was a great pilot study. It was a great small study that would say to us, we need to do a bigger study to see if what we find here is true. There was a selection bias that took years to recruit for this study, and there was a wide confidence interval. So again, great study, everybody should read it, but to realize we've sort of moved ahead in clinical studies. So this is an adult world, they tried to repeat it. This took the Markowitz approach, where it was a randomized clinical trial of 131 newly diagnosed Crohn's patients, and they looked for 18 months. Gave them 2.5 milligrams per kilo per day. They did not check levels. And the endpoint here was steroid-free remission with the Crohn's disease activity index of under 150. And at the end of the 18 months, the remission rate in the azathioprine group was 44%, and in the placebo group was 37%. The conclusion was that azathioprine was no more effective than placebo at 18 months. They did say that the azathioprine group was able to withdraw steroids at a greater rate than in the placebo group. And then this is another study, again, a little bit of a different design, a little bit of a different outcome. And again, when you read these studies, you need to look at what the outcome is. It was 132 patients, and again, steroid-free remission. And once again, they were unable to show much of an effect with the azathioprine use early. And so Athos did predict the future. This is the slide that he actually sort of explained well. This was the Walters study from the RISK trial, which I know many of us have participated in. And I forget exactly how Athos referred to the propensity score. It wasn't favorable. But it's actually, if you look at it, what it did is it looked at a number of variables that we all thought were important, and we tried to match patients equivalent. It's really the best we could do. Maybe there is some issues about it, but it did try to match patients. And what it showed is that, so they took patients, again, what they did is they took trios that were similar patients by this propensity score, and then they looked in to find somebody who, with the similar patient, one was given anti-TNF monotherapy, one immunomodulator, most of them are 6MP or azathioprine, and no immunomodulator. And this was, you had to give the therapy within the first 3 months of diagnoses. And what they showed is at the end of the year, the people who had gotten the monotherapy with the anti-TNF clearly did better, that are statistically more likely to be in remission. And it was interesting, the ones that were into the immunomodulator group, monotherapy was no different than the people who didn't do immunomodulators. Also, the thing that's interesting is patients were allowed to jump into another group. So a lot of the patients in the immunomodulator group or the no immunotherapy group did switch into anti-TNFs, but they still weren't able to sort of catch up with the anti-TNF people who had received it early. And again, I think one of the most important things is growth. The only group that grew was the group that was given the anti-TNF early after diagnosis. And the other two groups, again, at the end of 1 year, the kids did not improve their linear growth. So, risk mitigation strategy. Consider stopping thiopurines when clinically possible. Reduce risk after time off therapy. Consider drug holidays, change to methotrexate, yearly skin checks, avoid ionizing radiation. Consider primary anti-TNF therapy to moderate to severe IBD prior to thiopurines. The role of combination with methotrexate to increase durability needs to be done. And potential role of emerging drugs in decreasing cancer risk from therapies, maybe the anti-adhesion molecules, which they discussed earlier, the Adalimumab. Maybe in pediatrics will be a special group because of our concerns of these cancers, or it also might be the over 60, 65 group. Again, it might be something that will help. Okay, right, thank you.